Hi, Mike Gibson, Vivek Reddy, coming to you live from ESC 2023, and we are talking about the Advent study, a trial of pulsed field ablation versus thermal field ablation in paroxysmal AF. Talk to us a little bit about what you found.
Sure. Thanks so much for having me, Mike. So, as you know, atrial fibrillation ablation is a very commonly performed procedure in our field. And in the United States, the two technologies that we use that are most commonly employed are either radiofrequency ablation, meaning to heat tissue, or cryoablation to freeze tissue. Both these technologies work by transmission of thermal energy, meaning a propagation of the thermal wavefront, which ablates the tissue as it encounters it. And they're very effective technologies. They work very well, but there are some potential safety issues because both these thermal technologies, as the wavefront propagates beyond the myocardium, it can cause damage, for example, to the esophagus or the phrenic nerve. So we have to use various strategies to try to deal with those issues. There's a new type of ablation called pulse field ablation, which is not yet approved in the United States. It is approved in Europe for about just over a year and a half or so. And what's different about pulse field is it doesn't use temperature. Rather, it uses high energy, a couple thousand volts of energy, but for very short durations, just microsecond duration. And what that does is it destroys tissue by a process of electroporation, meaning basically punching holes in cell membranes to destroy the tissue. And there's a few other aspects to it. What's interesting about it is the number of the first in human studies and the preclinical studies indicate that this kind of ablation has some degree of selectivity toward ablating the myocardium. It's not perfect, but it's good enough that we can do it without, for example, affecting the esophagus. At least that's what the initial studies have indicated. And so based on this, the Advent trial is the first randomized trial comparing pulse field ablation to thermal ablation. And also, as it turns out, it's an FDA trial. So it's a trial used to gain FDA approval, and hopefully that will happen at some point. It is a randomized trial conducted in 30 centers in the United States, where patients who had paroxysmal atrial fibrillation who failed at least one antiarrhythmic drug were randomized to either pulse field ablation or thermal ablation. And thermal ablation could be either radiofrequency or cryo, where some of the centers were assigned to radiofrequency, meaning all their control patients go to radiofrequency, and some were assigned cryo. All of their control patients go to cryo. But the main randomization was between pulse field and thermal. So again, 30 centers. We had 65 operators that performed the procedures. The design was a Bayesian design that allowed us to look every 150 patients to see the aggregate event rates, and then based on that, look to stop at a particular point. So we were able to stop after 550 patients were analyzed, and by the time the stopping rule was hit, a total of 687 patients had been enrolled in the trial. Now, I should note, of those 687, 80 patients were the initial roll-in patients. So overall, 607 patients were ultimately randomized, either pulse field or thermal ablation. In the randomization, we should note it was almost 50-50, about 305, of the patients assigned to thermal ablation, about half got RF and half got cryoablation. So the patients were randomized. The primary endpoint was a composite of all the things you'd expect. Inability to perform the procedure properly, but most importantly, atrial fibrillation recurrence within the 12-month follow-up period. And also use of any antiarrhythmic drugs beyond a 3-month blanking period, any cardioversion, or certainly any repeat ablation after the initial procedure. So that was the primary endpoint. This was a Bayesian design, and this was designed as a non-inferiority trial. And indeed, the trial did meet the non-inferiority efficacy endpoint. So the success rate at 1 year was 73.3% in the pulse field group and 71.3% with the thermal group. Basically, the posterior probability for non-inferiority exceeded 99.9%, so basically non-inferior. Now, there was a secondary efficacy endpoint, which was basically if the primary endpoint was met, you could look to see if there was superiority, and not surprisingly, it was not superior. It was 73.3, 71.3. On the
What
safety
about
side,
complications? Yeah, what about safety then?
yeah, no, absolutely. Safety is critical. So the primary safety endpoint was a composite of the usual type of things we worry about: esophageal problems, pulmonary vein stenosis, tamponade, etc. And what we saw, and again, the primary was designed as a non-inferiority, and it did meet non-inferiority. So the complication rate was 2.1% in the pulse field group, and it was 1.5% in the radio frequency group. And that certainly met the posterior probability of non-inferiority, greater than 99.9%. And overall, we were pretty happy with that because in this trial, of the 30 centers, 65 operators, there was only one center that had any experience with this pulse field catheter. And remember that with radio frequency or cryoablation, these operators had, they'd done thousands of procedures. So given that its initial introduction, I think that was pretty favorable. Last point, there was a secondary safety endpoint, which was looking, it was again pre-specified. It was looking at aggregate pulmonary vein dimension between baseline versus 3 months. And part of the reason for this, just so you understand as background, is that pulse field doesn't seem to cause the same kind of tissue proliferation that thermal ablation causes. So the question was, would we see change in the caliber of the vein differentially between the two technology approaches? And indeed, that's what we saw. In the pulse field ablation group, there was no change. It was like a 3% difference in terms of vein diameter between baseline and 3-month CT scanning. Versus with thermal ablation, it was a diminution by about 17%. Now, that's not clinically significant, but it certainly speaks to the theoretical issue of pulmonary vein narrowing, certainly in pulmonary vein stenosis, presumably in a small percent of the patients. And this, by the way, did meet the criteria for superiority, posterior probability greater than 99.9% in favor of pulse field. And
Wow,
I
you
guess
know,
the
as an
final, oh,
interventional cardiologist, you just got my attention. Maybe we should put this in coronary arteries or something, ablating plaque this way. Wow. So go ahead. So how does this change practice? I mean, do you think, once it's reviewed, if it is approved by FDA, do you expect this would change practice?
yeah, I think it will, and part of it speaks to the last sort of outcome that I'll just mention. That these are not pre-specified, but it's the usual sort of procedural outcomes as you'd expect. And what was seen as procedure times were improved with pulse field compared to thermal ablation, and that's actually not a surprise because the pulse field lesions are like this, are microseconds long, so it's a quicker procedure. So when you combine quicker procedure, at least as effective, and certainly one wonders what happens as we get more experience whether pulse field effectiveness will go up higher, and certainly quite safe. Would you expect an uptake? I think so. I mean, if we look to see what's happened in Europe, for example, because pulse field has been available for a couple of years, we're seeing tremendous uptake in centers. In fact, the only real limitation in Europe, as far as I can tell, has been cost, because the catheters, as you'd expect, are more expensive.
Mhm.
So I think in the U.S., once it becomes approved, which presumably will happen next year, assuming it meets regulatory standards, then yeah, I expect that it'll see our shores and it'll end up becoming regular clinical practice in many of our patients, if not most.
Are there any cost effectiveness data out there from Europe or any plan from your study?
There isn't from Europe. There are definitely health economic studies that are a sub-study that is planned from the Advent trial. It'll be interesting to see utilization also because, unlike thermal ablation, pulse field doesn't seem to cause as much inflammation and other sort of things. And also patients, because the procedure time tends to be shorter, there are probably more patients that will end up going home on the same day after pulse field ablation. So I think this will have an impact. Still remains to be proven.
Well, Vivek, congratulations. Amazing. Great to see such an advance. This is why we do trials and do late breakers like this. Probably one of the more exciting things to come out of the meeting. Thanks for joining us today, and thanks to all of you in the audience for joining us.
Thanks, Mike.